Experimental and observational studies represent two fundamentally different approaches to research. In experimental studies, researchers actively control who receives an intervention. They assign subjects to different conditions and can directly measure cause and effect relationships. In contrast, observational studies involve researchers simply watching what happens naturally. They observe outcomes without controlling who receives an intervention, limiting their ability to establish causality. When it comes to the hierarchy of evidence, experimental studies, especially randomized controlled trials, are generally considered superior for evaluating interventions. The evidence hierarchy places experimental studies at the top, with randomized controlled trials considered the gold standard for evaluating interventions. However, observational studies are still extremely valuable in many scenarios. Observational studies are valuable when experiments would be unethical, when studying rare exposures or outcomes, when examining long-term effects, when studying large populations, or when generating hypotheses for future experimental research. Both experimental and observational studies have important and complementary roles in advancing our knowledge of public health and medicine. Randomized controlled trials, or RCTs, are considered the gold standard of experimental study designs in clinical research. The core principle of an RCT is randomly assigning participants to either an intervention group or a control group. This randomization process follows a structured flow, starting with eligibility assessment and enrollment, followed by randomization, and then follow-up and analysis. In an RCT, the control group might receive either a placebo, which is an inactive substance that looks like the treatment being tested, or standard care, which is the current best practice treatment for the condition. The comparison between the treatment and control groups allows researchers to determine the true effect of the intervention. Random assignment is a critical feature of RCTs because it minimizes selection bias and balances both known and unknown confounding factors between groups. This balanced distribution enables valid statistical inference and strengthens the ability to make causal claims about the intervention's effects. These design elements make RCTs the most powerful study design for determining cause and effect relationships in clinical and public health research. Randomized controlled trials, or RCTs, have several important applications in healthcare and public health research. RCTs are most commonly used to test the efficacy of drugs, evaluate new vaccines, and assess clinical interventions. Let's examine how RCTs are applied in vaccine development. In a typical vaccine efficacy trial, participants are randomly assigned to either receive the new vaccine or a placebo, an inert substance with no therapeutic effect. A landmark example of RCT application is the Physicians' Health Study. This was a large-scale 2x2 factorial design trial that tested two interventions simultaneously. The study tested whether aspirin reduced cardiovascular mortality and whether beta-carotene reduced cancer incidence. Over 22,000 male physicians participated in this groundbreaking trial. The aspirin component found a 44% reduction in risk of first myocardial infarction, while beta-carotene showed no significant effect on cancer risk. The Physicians' Health Study utilized a factorial design, which allows researchers to efficiently test multiple interventions in a single trial. In a 2x2 factorial design, participants are randomly assigned to one of four possible combination groups. This approach offers several benefits. It tests multiple interventions simultaneously, examines potential interactions between treatments, and provides a more efficient use of research resources by reducing the total number of participants needed. Randomized controlled trials, or RCTs, are considered the gold standard in research methodology due to several key advantages. The primary advantage of RCTs is that they are the gold standard for causal inference. This means they provide the strongest evidence for establishing cause and effect relationships. Randomization is a key element that eliminates selection bias. When participants are randomly assigned to treatment or control groups, the researcher's preferences or the participants' characteristics don't influence which group they join. RCTs ensure an unbiased distribution of confounding variables. Confounders are factors that can influence both the intervention and the outcome, potentially creating misleading correlations. Randomization distributes these confounders equally across groups. The most powerful advantage of RCTs is that they allow researchers to confidently attribute observed effects to the intervention itself. When researchers observe differences between treatment and control groups, they can be reasonably certain these differences were caused by the intervention, not by other factors. To summarize, the key advantages of randomized controlled trials include: they are the gold standard for establishing causal relationships. Randomization eliminates selection bias. They ensure equal distribution of both known and unknown confounding variables. They allow researchers to confidently attribute observed effects to the intervention. And they provide the strongest evidence for evidence-based practice and policy. Randomized controlled trials, while considered the gold standard for evaluating interventions, have several important disadvantages that researchers must consider. The first major disadvantage of RCTs is their high cost and logistical complexity. Running a rigorous RCT requires substantial resources, including large sample sizes, extended follow-up periods, staff training, and sophisticated data management systems. A second critical disadvantage involves ethical constraints. It would be unethical to withhold potentially life-saving treatments from a control group. For example, once a treatment shows clear benefits, continuing to randomize participants to receive a placebo would violate ethical principles. Researchers must maintain equipoise, genuine uncertainty about which treatment is best, and ensure an acceptable risk-benefit ratio for all participants. These ethical requirements can limit when and how RCTs can be conducted. Ethical research follows key principles like reasonable risk-to-benefit ratio, scientific validity, and fair participation. These essential principles can sometimes limit when randomization is appropriate. The third major disadvantage is effect modification. RCT results may not generalize across different populations because causal chains in public health interventions are complex. Effect modification occurs when the intervention's impact varies based on characteristics like genetics, socioeconomic status, or cultural factors. For example, smoking and asbestos exposure together create a much higher lung cancer risk than either factor alone, demonstrating how multiple factors can interact to influence outcomes. Beyond these major disadvantages, RCTs face practical implementation challenges. Selection bias can occur if recruitment is difficult. High dropout rates threaten validity. Some public health interventions cannot be blinded, and strict eligibility criteria can limit how well results generalize to real-world settings. In summary, while RCTs are powerful research tools, they come with significant disadvantages, including high costs, ethical limitations, effect modification concerns, and practical implementation challenges. Researchers must carefully weigh these factors when designing studies. Cluster randomized trials use a different approach to randomization. Instead of randomizing individuals to different interventions, cluster randomized trials randomize entire groups or units. To understand cluster randomization, let's first compare it with individual randomization. In individual randomization, each participant is independently assigned to an intervention group. In contrast, cluster randomization assigns entire groups of participants to interventions together. Cluster randomized trials can use various types of clusters or groups. Common examples include schools, where all students in selected schools receive the same intervention. Villages or communities, where all residents are assigned to the same intervention group. And health clinics, where all patients at particular clinics receive the same intervention. The randomization process in cluster trials follows a specific sequence. First, researchers identify the clusters to be included in the study, such as schools, villages, or clinics. Next, they assess the eligibility of these clusters based on study criteria. Then, eligible clusters are randomly assigned to different intervention groups. Finally, all individuals within each cluster receive the intervention assigned to their cluster. Cluster randomization is particularly useful in certain situations. First, when interventions are naturally applied at the group level, such as educational programs in schools. Second, to minimize contamination between treatment groups, which can occur when individuals interact and share intervention components. And third, when it's logistically easier or more cost-effective to implement an intervention at the group level. To summarize, cluster randomized trials are designed to randomize groups rather than individuals. They are characterized by randomizing entire clusters, such as schools, villages, or health clinics, where all individuals within a cluster receive the same intervention. This design is particularly valuable for public health interventions that are best applied at the community or group level. Cluster randomized trials are applied in various public health settings where group-level interventions are essential. First, cluster randomized trials are commonly used in community sanitation projects. These include testing water purification methods, comparing sanitation infrastructure, and evaluating waste management programs at the community level. Health education campaigns are another important application. These trials evaluate disease prevention awareness, nutrition education programs, and maternal health training initiatives where entire communities receive the same educational intervention. For infectious disease programs, cluster randomized trials are essential. They're used to study vaccine efficacy, establish disease surveillance networks, and implement infection control interventions at the community level. In developing countries, cluster randomized trials are particularly valuable. Entire villages or regions are often randomized to receive interventions like healthcare programs or community health worker training. Finally, schools provide an ideal setting for cluster randomization. Schools are randomized to implement physical activity programs, mental health initiatives, or nutrition interventions, with the entire school serving as the unit of analysis. To summarize, cluster randomized trials are ideal for community-based interventions where individual randomization is impractical, programs naturally implemented at the group level, settings where contamination between intervention and control is likely, evaluation of indirect effects, and programs targeting behavior change in social units. In this section, we'll explore the key advantages of cluster randomized trials, also known as group randomized trials. The first major advantage of cluster randomized trials is reduced contamination between individuals. Contamination occurs when participants in the control group are indirectly exposed to the intervention, which can dilute the measured effect. As shown in this image, individual randomization can lead to contamination when patients from different groups interact with the same clinician. With cluster randomization, entire groups like clinics or communities receive the same intervention, minimizing this crossover effect. The second advantage is that cluster randomized trials are practical for population-level interventions. These trials are ideal for interventions that naturally operate at a group or community level. Examples include public health campaigns, water treatment programs, school-based health education, and community vaccination initiatives. This population intervention triangle illustrates how different levels of interventions work together in public health. Cluster randomization is particularly effective for community-centered and service-based interventions shown here. The third advantage combines logistical convenience and ethical considerations. Cluster randomization can be more feasible and ethically appropriate in certain contexts. This includes situations where interventions can only be delivered to groups, when infrastructure limitations exist, when cost-effective implementation is needed, or when community consent is more appropriate than individual consent. These ethical principles illustrated here are important considerations in research. Cluster randomization can sometimes better respect community autonomy and dignity while promoting justice in research participation. To summarize, cluster randomized trials offer 4 key advantages. They reduce contamination between study groups, they're practical for population-level interventions, they can be logistically convenient, and they may be more ethically appropriate in certain contexts. When designed and implemented correctly, cluster randomized trials allow researchers to effectively study interventions at the population level while maintaining scientific rigor. Cluster randomized trials come with several important disadvantages compared to individually randomized trials. First, cluster randomized trials require larger sample sizes than individual randomized trials. This is because individuals within the same cluster tend to be more similar to each other than to individuals in different clusters. This similarity is measured by the intra-cluster correlation coefficient, or ICC. As the ICC increases, the effective sample size decreases, requiring researchers to enroll more clusters or more participants per cluster to maintain statistical power. Second, cluster randomized trials require more complex statistical analysis. Standard statistical methods assume independence between observations, but this assumption is violated in cluster designs where participants within clusters are correlated. Researchers must use specialized methods like hierarchical or multi-level models to properly account for the correlation structure. This adds complexity to both the analysis and interpretation of results, often requiring specialized statistical software and expertise. Third, cluster randomized trials can be more difficult to design. Researchers must carefully select appropriate clusters and address issues such as varying cluster sizes and logistical complexities of implementing interventions at the group level. Finally, cluster randomized trials are more prone to certain biases. Selection bias can occur when there are systematic differences between clusters. Recruitment bias emerges when participants are enrolled after clusters are randomized, and baseline imbalances are more common with fewer randomization units. To summarize, while cluster randomized trials offer important advantages for certain research questions, they come with significant challenges. They require larger sample sizes, demand more complex statistical analysis, are more difficult to design properly, and have increased vulnerability to various biases. Researchers must carefully consider these disadvantages when deciding whether a cluster randomized design is appropriate for their study. Crossover trials have specific applications in clinical and public health research. In a crossover design, each participant receives both treatments in sequence, separated by a washout period. Crossover trials are particularly suitable for several applications. These include short-term drug testing, digital health product evaluation, treatments with quickly reversible effects, and symptom management interventions. Let's look at some specific examples where crossover trials are effectively applied. In pharmaceutical research, crossover designs are ideal for testing short-term medications like pain relievers, anti-anxiety treatments, sleep aids, and migraine medications. These drugs typically have effects that wear off quickly, making them suitable for crossover studies. Digital health researchers also benefit from crossover designs when evaluating health tracking apps, meditation programs, fitness interventions, and behavior change tools. This allows comparison of different versions of digital interventions within the same users. It's equally important to understand when crossover trials are not appropriate. Crossover designs are unsuitable for treatments with irreversible effects, long-lasting interventions, progressive conditions where patient status changes over time, and studies with high dropout risk, as both treatments must be completed by each participant. A critical consideration in crossover trial applications is the washout period. This period must be long enough to eliminate any carryover effects from the first treatment before the second treatment begins. The appropriate length of the washout period is typically determined by the half-life of drugs being tested or the expected duration of intervention effects. An insufficient washout period can introduce bias and compromise the validity of results. Crossover trials offer several important advantages in public health research. The fundamental design of crossover trials allows each participant to receive multiple treatments in sequence. The primary advantage of crossover trials is that participants serve as their own controls. This design reduces intersubject variability by eliminating between-subject differences as each participant experiences all treatment conditions. This graph illustrates how crossover designs can capture both between-subject and within-subject variation, allowing for more precise comparisons. Crossover trials provide enhanced statistical power compared to parallel designs. This means researchers can detect treatment effects with fewer participants, achieve more precise estimates, and identify smaller differences between treatments. The statistical model for crossover designs accounts for treatment effects while controlling for period and sequence effects. Perhaps the most practical advantage is the reduced sample size requirement. In many cases, a crossover design can achieve the same statistical power with approximately 1/4 of the participants needed for a parallel design. This leads to more efficient research with lower recruitment costs and faster completion times. Let's summarize the key advantages of crossover trials in public health research. These advantages make crossover designs particularly valuable for certain research questions, especially when studying treatments with short-term effects and conditions that remain stable over time. Crossover trials, while beneficial in many ways, have several important disadvantages. The first major disadvantage is the risk of carryover effects. This occurs when effects from an earlier treatment period persist and influence the response during subsequent treatment periods. If the washout period between treatments is insufficient, this can seriously compromise the validity of the study results. The second disadvantage is that crossover trials require subjects' conditions to remain stable throughout the entire study period. This can be particularly challenging for chronic or progressive conditions. Any natural changes in the subject's health status can confound the measurement of treatment effects. A third important disadvantage is order effects. The sequence in which treatments are administered can influence the results independently of the treatments themselves. For example, subjects might respond differently to the second treatment due to practice effects, adaptation, or expectations based on their experience with the first treatment. Finally, crossover trials place a higher burden on participants. Since each participant receives all interventions being studied, they must commit to a longer study duration and potentially experience side effects from multiple treatments. This can lead to higher dropout rates, which complicates analysis and may introduce selection bias. When designing a crossover trial, researchers must carefully consider these disadvantages. While proper design elements like adequate washout periods and counterbalancing treatment orders can mitigate some issues, certain research questions may be better addressed using alternative experimental designs. Factorial trials have several important applications in health research. One major application is in health interventions, where factorial designs can test interactions between different treatment components. For example, researchers can simultaneously evaluate both diet and exercise interventions to determine if their combined effect is greater than the sum of their individual effects. Another key application is in digital health, where multiple app features or intervention components can be tested efficiently. The fundamental structure of a factorial design allows researchers to test multiple interventions in a single experiment. Let's look at some specific examples of factorial trials in health research. In a weight loss program, researchers might compare different diet types and exercise intensities simultaneously, allowing them to identify the most effective combination. For smoking cessation apps, factorial designs can test how reminder frequency interacts with different types of incentives to maximize quit rates. Similarly, medication adherence interventions can test combinations of reminder systems and content types to find the optimal approach. A key benefit of factorial designs is their ability to reveal interactions between variables, where the effect of one factor depends on the level of another. This visualization shows how temperature and carbon dioxide levels interact in an environmental study. Notice how the effect of temperature differs depending on the carbon dioxide concentration. To summarize, factorial trials offer valuable applications in health research, allowing researchers to efficiently test multiple interventions and identify important interactions. Equipoise is a foundational ethical principle in experimental research. It refers to a state of genuine uncertainty within the clinical and scientific community about which treatment approach is best. When equipoise exists, researchers can ethically conduct randomized trials because there is true uncertainty about the superior intervention. Equipoise requires that researchers must not knowingly assign participants to an inferior treatment. If evidence clearly suggests one treatment is better, randomization becomes ethically problematic. Equipoise can be challenged in several ways. As evidence accumulates during a trial, the balance of uncertainty may shift. This is when ethical questions arise. Patient beliefs and preferences can also affect equipoise. Some participants may have strong preferences for one treatment arm over another. External pressures, such as financial interests or publication bias, may also threaten the integrity of equipoise in research. Ultimately, equipoise balances scientific advancement with ethical responsibility to participants. It ensures that research serves both scientific discovery and the welfare of participants. The research question is the most important factor in choosing a study design. Research follows a hierarchical structure, from the broad research paradigm down to specific instruments. Your research question should align with this hierarchy. Different types of research questions call for different study designs. For questions about causality, randomized controlled trials are often optimal. This comparison table shows various study designs and their characteristics. Different designs answer different types of questions and have varying levels of evidence. When choosing a study design, consider several key factors. These include how specific your research question is, whether you need to establish causation, the level of evidence required, and the characteristics of your target population. If your primary goal is to establish causality, to definitively determine if X causes Y, then a randomized controlled trial is often the best choice, as it provides the highest level of evidence for causal relationships. When choosing a study design, it's crucial to consider the resources available to you. The three primary resources to consider are budget, time, and sample size. Budget is often the most limiting factor. Different study designs have varying cost implications, similar to how service plans are tiered based on features. RCTs are typically the most expensive design, followed by cluster and factorial trials. Crossover trials can be more cost-effective since they require fewer participants. Time is another critical resource. Each study design has different time requirements, from planning through data collection to analysis. RCTs typically have longer timelines due to recruitment, follow-up, and more complex protocols. Crossover trials are often shorter due to fewer participants needed, while cluster trials require time to organize group-level interventions. Factorial designs can be efficient for testing multiple interventions simultaneously. Sample size requirements vary significantly between study designs. As shown in this table, larger sample sizes increase statistical power and decrease p-values, making true effects more detectable. Cluster randomized trials typically require the largest sample sizes due to intra-cluster correlation. Crossover trials need fewer participants since subjects serve as their own controls. RCTs and factorial trials fall somewhere in between. Here are some tips for optimizing your resources. Consider conducting pilot studies to better estimate resource needs. Leverage adaptive designs, existing data sources, and partnerships to maximize efficiency. And always calculate the minimum detectable effect size your budget allows. When resources are limited, this matrix can help select the most appropriate design. Crossover trials excel when budget, time, or sample size is limited. Factorial designs offer a balanced approach, while RCTs can be modified to fit resource constraints while maintaining internal validity. Remember, the optimal study design balances your scientific goals with the resources you have available. No single design is perfect for all scenarios, so consider your specific constraints carefully. When choosing an experimental study design, ethical considerations are paramount. Certain ethical concerns may preclude the use of specific study designs. One major ethical consideration is whether it's acceptable to withhold treatment from a control group. This is particularly concerning when the condition being studied is serious and effective treatments already exist. All research designs must adhere to fundamental ethical principles, including obtaining informed consent, maintaining confidentiality, and allowing participants to withdraw at any time without consequences. Crossover trials present specific ethical challenges. They are not suitable when treatments have irreversible or long-lasting effects, as this could harm participants or invalidate results. Additionally, exposing all patients to both treatments, potential harm during washout periods, and disease progression during the study are significant ethical concerns in crossover designs. Beyond ethical considerations, study designs must also comply with legal and regulatory requirements, including institutional review board approval and relevant data protection laws. When choosing a study design, researchers should use an ethical decision framework that considers key questions about the intervention and study population. First, determine if withholding treatment from a control group is ethical in your specific context. If yes, a randomized controlled trial might be appropriate. If not, consider alternative designs and ask whether the treatment effects are reversible. This will help determine if a crossover design is ethically appropriate or if another design like Factorial might be better. Above all, remember to always prioritize participant safety and rights when selecting a study design. Ethical considerations should never be compromised for the sake of scientific rigor. We've explored the world of experimental study designs in public health research. Experimental studies deliver the strongest causal evidence available to researchers. However, they demand rigorous planning, comprehensive ethical safeguards, and meticulous analysis of results. When designing your study, remember to choose the methodology that best fits three key considerations. First, your research question. Different designs answer different types of questions. Second, your available resources, including time, budget, and sample size. And third, ethical considerations, ensuring participant welfare while advancing knowledge. We've discussed 4 major experimental designs, each with unique strengths for different research contexts. Thank you for exploring experimental study designs in public health research.